Hello, my name is Sarah McElwee, and I will be discussing, through this guided PowerPoint, what Parkinson's disease is. Parkinson's disease is often heard in the medical world and often in day-to-day life by means of family, friends, and even TV as more and more people begin to age and develop degeneration. But what exactly is Parkinson's disease? Today, with the help of research in this PowerPoint presentation, I am here to explain what Parkinson's disease is, what brain structure is affected, how the brain structure is changed, the effect it has on an individual's communication, and finally, what a speech-language pathologist can do to aid in the progressing symptoms. In this presentation, I will be focusing on the motor aspect of Parkinson's disease and what the dysfunctions affect in someone who has acquired this disorder. So let me start out by giving an overview of what Parkinson's disease is. Parkinson's disease is a degenerative disease that is due to the inefficiency or loss of the production of the neurotransmitter known as dopamine. Normal, unaffected brain neurons are responsible in the production of dopamine. Dopamine allows signals to pass from one region of the brain to another. When an individual develops Parkinson's disease, these neurons that produce dopamine are either damaged or completely destroyed. Also, Parkinson's disease can be caused by a disruption in the basal ganglia thalamocortical motor circuit. We will talk more about the motor circuit in the next slide. So what is the motor circuit? The motor circuit, otherwise known as the basal ganglia thalamocortical motor circuit, has both origins and terminals which are located in the premotor and postmotor regions of the brain. Specifically, these regions are the supplementary motor area, the coagulate motor area, the motor area, and the premotor area. The origins of the motor circuit project into the striatum, the putamen, and the postcommissural caudate nucleus. The motor areas of the subthalamic nuclei are also included. Each origin of the neurologic responses reflects the organization of connections between the motor circuit, the thalamus, and the basal ganglia. The motor circuit is responsible for regulating and controlling movements, planning the movements, and giving expression to the movements. Finally, it is also part of the extrapyramidal system. Moving on, we will now talk about what the impaired brain structure is that's associated with Parkinson's disease. The areas of the substantia nigra, or SN, and the ventral tegmental area, or VTA, are the first regions early in the progression of Parkinson's disease that experiences significant degeneration of dopamine. However, the ventral tegmental area will most likely keep its production of the neurotransmitter dopamine longer than the substantia nigra will. The substantia nigra has two parts, one being the pars compacta and the other one being the pars reticulata. The pars compacta is the area of the substantia nigra to degenerate and cause the production of dopamine to lessen. At least 70 to 80% of dopaminergic neurons in the pars compacta of the substantia nigra are lost before the onset of the clinical symptoms of Parkinson's disease. With that being said, a great deal of pars compacta neurons are lost before Parkinson's disease symptoms even occur. Here I have included a picture of the substantia nigra to give a better view of where it is located in the brain. The substantia nigra is the two areas that are seen here on each side in black. To the left is a picture of a normal substantia nigra with the two black sides here, compared to a degenerated substantia nigra due to Parkinson's disease, and you see that the substantia nigra has deteriorated. Now we will move on to what the changes in brain function are. As you have heard earlier, dopamine production in the basal ganglia motor circuit are important to ensure proper functioning in the brain. A lack of dopaminergic innervation to the striatum will ultimately affect the brain's functioning by reducing an individual's motor movements. On the other hand, when there is a disturbance in the motor circuit that goes from the basal ganglia to the cortical and subcortical structures of the brainstem and thalamus, movement disorders will follow. Such movement disorders as hypokinesia are the most common to occur, especially in Parkinson's disease. The main motor symptoms of Parkinson's disease are tremors, which occur at rest, rigidity, postural instability, and akinesia, which is the impairment of voluntary motor control. Hypokinesia is a movement disorder that is characterized by a lessened activity of one's muscles. Bradykinesia is somewhat similar, but is seen to cause slow movement, stiffness, and shakiness. The motor dysfunction symptoms usually begin in the early stages of Parkinson's disease as unilateral, meaning only on one side, but then unfortunately progress to the rest of the body. Non-motor symptoms are not the primary focus of this PowerPoint, but I wanted to briefly go over the basis. Non-motor symptoms can occur in the form of mental disturbances, such as dementia, anxiety, and depression. Problems with sleeping, such as restless leg syndrome and rapid eye movement, are also a concern. Autonomic functions such as bowel function, postural hypotension, which is when your blood pressure drops as you stand up, and weight loss have been reported. Finally, a disease-related pain known as dystonia can be present. Now we will discuss what symptoms of Parkinson's disease affect a person's communication skills and why. Starting with the oral musculature, the tongue and the lips have a slower rate, and palatal movement may be diminished. DDK rate, or otherwise known as diadochokinetic rate, is when patients are asked to repeat a syllable sequence such as padaka, and persons with hypokinetic dysarthria will show a reduction in the range of movement, but a more rapid speaking rate. Hypokinetic dysarthria is commonly associated with Parkinson's disease. As for phonation, laryngeal disorders were found to be prominent in persons with Parkinson's disease, with the percentage of occurrence being around 89%. Symptoms of hoarseness, roughness, breathiness, and tremulousness existed, with hoarseness being the most common with a 45% occurrence. Dysphonia seems to be the speech feature with the most detrimental loss. Vocal production also includes monoloudness and monopitch, and the production of adequate intensity when phonating is difficult with patients with Parkinson's disease. In terms of articulation in individuals who have hypokinetic dysarthria, manner of articulation was most affected compared to place of articulation and voicing versus devoiced. The manners affected included plosives, fricatives, and affricates. When the person's tongue is not elevated at the right time or in the right manner, an incompetent constriction of the vocal tract is present and is known as articulatory undershoot. Moving on to resignation, only a small percentage of people have been reported to experience resonance disturbances. However, the ones who did reported hypernasality. With prosody, 20% of individuals with Parkinson's disease exhibit what is known as a rate disorder. Parkinson's patients can use syllables that are too long, they can use syllables that are too short, and they can make use of abnormally long pauses. Other issues of prosody and rate include inappropriate silences and short rushes of speech. Syllable repetition has been present in people with Parkinson's disease as well. Palilalia is seen in Parkinson's disease and is characterized by repetitions that usually involve words, phrases, or sentences and is usually associated with bilateral subcortical damage. To swallow, there are 4 stages that complete the process. In Parkinson's disease, trouble swallowing or dysphagia are seen throughout. A rocking pattern may be present with the front of the tongue moving the bolus back and forth, while the posterior tongue is elevated, and overall this prevents the food from being swallowed. Aspiration is another problem in the stages of swallowing, where the swallow response is delayed and food goes down the wrong hole. Aspiration occurs in people with Parkinson's disease as silent and without coughing, and without ever having been previously diagnosed or had a history of it. As time passes and the disease progresses, signs and symptoms of dysphagia are known to worsen, and medication can actually exacerbate the problem. Now, to end this presentation on Parkinson's disease, I want to talk about what an SLP, or speech-language pathologist, would work on with a patient with Parkinson's. A speech-language pathologist can provide several areas of therapy with a patient with Parkinson's. First, the loudness and pitch of a person's voice can be improved. Second, the intelligibility of an individual's speech sounds are assessed and treated based on the effect on communicating with others. If it is necessary, augmentative devices that assist the person in speaking can be issued, and the SLP will make sure that the desired level of conversation is maintained. Besides voice complications, the patient with Parkinson's may also receive therapy designed to help with the risk of aspiration due to improper swallowing habits.